Hi guys, welcome back to my channel obgyn Made Easy. Today I'll be discussing Prom. Prom stands for Premature Rupture of Membranes. It's also known as Pre-labor Rupture of Membranes, but commonly known as Premature Rupture of Membranes. Prom is rupture of membranes after 28 weeks gestational age, but before the onset of labor at term. At term is 37 weeks gestational age or more. At term, we expect the baby to have matured. Now, why do we use 28 weeks of gestational age? You remember in my previous videos, I explained that 28 weeks gestational age is the age of viability in developing countries. Whilst in developed countries, they use as little as 24 weeks gestational age. So it depends which country you are in. Basic anatomy. The uterus is made up of three muscle layers, the outer layer being the perimetrium, the middle layer being the myometrium, the inner layer being the endometrium. Now remember, the amniotic sac is made up of two fetal membranes. There's an outer fetal membrane and an inner fetal membrane. The outer fetal membrane is known as the chorion. The inner fetal membrane is known as the amnion. So these two fetal membranes make up the amniotic sac. Inside here you have your amniotic fluid surrounding the fetus. Here you have your vagina. Here there's a mucus plug. A mucus plug is protective in pregnancy in the sense that it prevents infection from ascending from the lower genital tract to the upper genital tract. And here you have the external os of the cervix, and here you have the internal os of the cervix. So what do we mean by rupture of membranes? Rupture of membranes is where this amniotic sac here gets torn. It loses its integrity. So you have a torn amniotic sac here, and the end result is amniotic fluid which oozes outside. Incidence. Prom occurs in approximately 10% of all the pregnancies. Prom is the leading cause of prematurity. About 50% of the cases of prematurity are caused by Prom. This is because I said Prom occurs before 37 weeks gestation age. This is before term. You expect the fetus to not have fully matured. Definitions. Prom. Prom is preterm premature rupture of membranes before 37 weeks gestational age. The difference between Prom and Prom is the gestational age. Prom is mostly associated with prematurity because it's less than 37 weeks gestation age. It occurs before 37 weeks gestation age. It can occur as early as 30 weeks gestation age. Whilst Prom occurs at term at 37 weeks gestation age or more. So you expect the fetus to have developed by then. Whilst in Prom, if it occurs at 30 weeks gestation age, most likely the fetus has not yet fully matured. So it's associated mostly with prematurity. Prolonged rupture of membranes is rupture of membrane that persists more than 24 hours and before the onset of labor. So if a patient's membranes have been ruptured and she does not go into labor after 24 hours, this is known as prolonged rupture of membranes. You have to do something about it. Spontaneous preterm rupture of membranes. This is rupture of membranes after or with the onset of labor occurring before 37 weeks gestation age. Etiopathogenesis. The fetal membranes, that is the amniotic sac, which is made up of the inner amnion and the outer chorion. These are strengthened by collagen, which under normal circumstances become weaker at term in preparation for labor. So only at term should the fetal membranes become weak. If the patient is not yet nearing term, the fetal membranes are supposed to be strong. Okay, So the physiological processes underlying this weakening includes apoptosis. Apoptosis, if you remember in your pathology, is self-destruction. And there's collagen breakdown by enzymes like MMP. This is matrix metalloproteinase. So there's a natural physiological mechanisms including Braxton Hicks contractions and cervical ripening, which lead to weakening of the membranes. However, in Prom and P-Prom, a combination of factors can cause weakening and rupture of membranes. So in Prom and P-Prom, there's early activation of normal physiological processes which should be which shouldn't be there. So there's higher than normal levels of apoptic markers and matrix metalloproteinase enzymes in the amniotic fluid, which break down the collagen of the fetal membranes. But in most cases, the cause, however, is not known. So in normal circumstances, when a patient is not nearing term, the fetal membranes are supposed to be strong, reinforced by collagen. But in Prom and P-Prom, these fetal membranes are weak. Risk factors of Prom and P-Prom: lack of resistance of membranes like abnormal membrane physiology caused by genetic predisposition of collagen disorders, and vitamin C deficiency. Remember, vitamin C is important in the formation of collagen, cartilage, bone and tissues, and wound healing. Invasive procedures like amniocentesis. Amniocentesis is a small procedure where you remove amniotic fluid from the amniotic sac. So you have a needle that goes into the amniotic sac, which removes amniotic fluid. So this procedure can disrupt the integrity of the amniotic sac, which can cause Prom. Cone biopsy. It's a small procedure where you remove some of the cervical tissues up here. So what happens is, once you're removing some of this cervical tissue, you might end up disrupting the fetal membranes, causing Prom. In polyhydramnios, there's more amniotic fluid than is required. So what happens is the pressure in the amniotic sac is increased, which actually stretches the amniotic sac, the fetal membranes, which can cause rupture in the fetal membranes. In multiple pregnancy, you have let's say a twin pregnancy here. So as the fetus grow, or let's say the feti grow, there is increased pressure on the amnion, the inner sac here, the inner fetal membrane. So what happens is, as the feti grow, the pressure increases, which can disrupt the integrity of the amniotic sac. Cervical incompetence. This is cervical weakness. It's a condition in which the cervix begins to dilate and efface before the pregnancy reaches term. So there's premature cervical dilatation and premature cervical effacement. Effacement is thinning of the cervix. So once this occurs, you expect contractions to start, because it's more like a trigger of preterm labor. So where there's preterm labor, there's either spontaneous rupture of membranes or artificial rupture of membranes. That's how Prom occurs. In where there's cervical length less than 2.5 centimeters. Remember that the normal cervical length is supposed to be at least 2.5 to 3 centimeters. So if the cervical length is less than 2.5 centimeters, if it's less than 2.5 centimeters, it can end up into premature cervical dilatation and premature cervical effacement. Other risk factors like previous preterm labor and previous Prom also carry risk in the next pregnancy. Smoking has been associated with Prom, and also history of trauma. Okay. Vaginal bleeding during pregnancy. This is where, let's say, you have bleeding, let's say, from the placenta. So the blood will be going down here, down here. It will be separating the amniotic sac from the endometrium, which can result into rupture of the membranes. Infections like chorioamnitis, urinary tract infections, and lower genital tract infection. Chorioamnitis is inflammation and infection of the chorion and the amnion. Bacteria produces its own enzymes like protease and phospholipids. And on top of that, the body also produces macrophages to get rid of the bacteria. So what happens? There's an interaction. There's bacterial production of its own enzymes, and then you have macrophages which try to engulf this area where there is bacteria. So the end result is chewing off of the fetal membranes here, which can result into Prom. Low socioeconomic status has been associated with Prom, P-Prom, and preterm labor. This is most probably because of poor sanitary conditions. So they are predisposed to, let's say, poor hygiene. They are at high risk of urinary tract infections and lower genital tract infections, and also of because of poor nutrition. So probably because of micronutrient deficiency like zinc and vitamin C. So remember, these two are important in collagen formation. They strengthen the connective tissues. Low BMI has also been associated with Prom, P-Prom, and preterm labor. Clinical features of Prom and P-Prom. Even though the topic says Prom, the etiopathogenesis, clinical features, and other like that are all the same in Prom and P-Prom. The only difference between the two is the gestational age that it occurs. Prom occurs at term, P-Prom occurs before term. Okay. So there's history of painless popping sensation. The popping sensation is from the rupture of the membranes, which is followed by a gush of fluid per vagina. So there's a gush of the amniotic fluid that comes out of the vagina. So not all the time there'll be a gush of fluid. It might be a slow per vaginal leakage of watery fluid. Gush of fluid is a fast flow. Okay. Or the patient might wake up in the morning with a wet underwear. There might be a mucoid blood stain per vaginal discharge. This mucoid blood stain per vaginal discharge is simply the mucus plug falling off. So in your history, ask about the color or consistency of the vaginal discharge to help you distinguish from other causes of the vaginal discharge. What if it's not a Prom? So Prom is associated with increased pelvic pressure. This is because of the flow of fluid, and there will be no contractions. So it's important in your history to find out if the vaginal discharge reaches the toes. Usually, if there's a watery discharge and it's amniotic fluid, it might actually reach the toes. Whilst if it's just a urinary tract infection or because of abnormal vaginal discharge, it will not reach the toes. Differential diagnosis of Prom and P-Prom. You can have urine incontinence. In urine incontinence, there's uncontrolled leakage of urine. So you have urine dripping down outside the vagina, which can actually also reach the toes. So you have to differentiate it from Prom. Hydroria gravidarum. This is a normal periodic watery discharge that occurs in pregnancy. This is due to excessive glandular secretion of the decidua. In urinary tract infection, you can have abnormal vaginal discharge. Usually it's brownish vaginal discharge. In bacterial vaginosis, this is a bacterial infection caused by an imbalance of the normal flora. So there's overgrowth of normal flora. It's also associated with the vaginal discharge. In leukocoria, you have normal odorless vaginal discharge from the vagina. It may be white or yellowish in color. In vesicovaginal fistula, this is where you have a fistula between the bladder and the vagina. So you find that urine seeps from the bladder into the vagina. So you might actually think it's a Prom. A vesicovaginal fistula is between the bladder and the vagina. Or you can have falling off of that mucus plug we mentioned, which you might think is also Prom. So these are the differential diagnosis of P-Prom and Prom. Having talked about the differential diagnosis of Prom and PPROM, how do you confirm that this case is a Prom or a PPROM? First of all, don't do a vaginal examination where you're suspecting the patient has Prom or PPROM. This is because the amniotic sac, where the amniotic fluid is a sterile environment. And because you're suspecting Prom, that there's a rupture of these membranes, you might introduce infection with your vaginal examination into the amniotic fluid, which can end up into a chorioamnitis. What you do instead is a sterile speculum examination. Now, before you do a sterile speculum examination, ask the patient to sit at least for 30 minutes. This is to allow for fluid to collect in the vagina. So when you put your sterile in the vagina, you will notice pooling of fluid in the posterior vaginal fornix coming out of the cervix. Where you don't see any fluid coming out of the cervix, this is most probably because the patient drained a lot and has lost a lot of amniotic fluid. Ask the patient to cough. This is a Valsalva maneuver. You might see fluid coming out of the cervix. Okay. Now, you should note the color, the smell, and the consistency of the fluid. And also make sure you rule out a cord prolapse. You might have a cord that is protruding outside the cervix. Before you remove the speculum, do a high vaginal swab for microscopic culture and sensitivity. Suppose there's a bacteria growing there, so you want to culture it, and sensitivity will tell you the antibiotic that organism is vulnerable to. To confirm that what you're seeing is amniotic fluid, you can do a Furning's test. A Furning's test is where you dry off the fluid on a slide and visualize it under microscopy. So what you see under microscopy is a characteristic fern-like appearance like this, like a flower. Okay. Another test to confirm this is a litmus or nitrogen test. What it does is it detects the pH. So normal pH in pregnancy in the vagina is about 4.5 to 5.5. So if this pH has been contaminated with amniotic fluid, it will go to about 6 to 6.2. The pH will go to about 6 to 6.2. The normal amniotic fluid pH is 7 to 7.5. Now, between this, if the amniotic fluid reaches the vagina, it will bring the pH to about 6.62. 6 to 6.2. So this is diagnostic of a Prom. And then the litmus paper or nitrogen paper turns from yellow to blue at a pH of 6 to 6.2. Other fancy tests you can do are actin Prom. This is a rapid test. It detects for insulin-like growth factor binding protein 1. Insulin-like growth factor binding protein 1 is also known as placenta protein I2. It's found in the endometrium. So if your rapid test is positive, this is diagnostic for Prom. Actin Prom is actually more accurate and sensitive for Prom. Amisure is another rapid test. It tests for placenta alpha microglobulin 1. Placenta alpha microglobulin 1 is found in amniotic fluid in large concentrations than in blood or the cervical vaginal fluid. So these are the two rapid tests you can do that are also confirmatory for Prom. Investigations you can also do in Prom. Investigations you can do in Prom and PPROM. A full blood count or differential count to look for leukocytosis. Urine for urinalysis, microscopic culture and sensitivity in case there's an organism growing there or there's a urinary tract infection associated with the Prom. C-reactive protein and erythrocyte sedimentation rate. These are inflammatory markers. Okay, so the normal C-reactive protein is supposed to be less than 10 milligrams per liter. These are non-specific tests because they just tell you that there's an inflammation or an infection going on. Whilst the normal ESR should be less than 20 millimeters per hour. So these are non-specific. They'll just tell you there's an infection or inflammation going on. The high vaginal swab, we already talked about it. And then you order an ultrasound for a fetal biophysical profile and the amniotic fluid. Remember that these patients are losing amniotic fluid, so you have to see if there's enough amniotic fluid. Cardiotocograph or non-stress test. This is used to monitor the fetal heart rate, basically the fetal status, if the fetus is uh, strong enough to survive labor. Complications of Prom and P-Prom. There's maternal complications and fetal complications. So for the maternal complications, you can have choriamnitis. So the choriamnitis can actually result into maternal sepsis. Okay. And because of the choriamnitis as well, you can end up with endometritis. You can have a placental abruption, or you can have a retained placenta. Retained placenta. The fetal complications are more in P-Prom than in Prom. This is because in P-Prom it occurs before term, before 37 weeks gestation age. So it can occur at 30 weeks, 32 weeks, 34 weeks, or 36 weeks gestation age. Whilst Prom occurs at term, it occurs at 37 weeks gestation age going upwards. So the risk factors are more in P-Prom than Prom. P-Prom is associated with prematurity. So you can have prematurity. This is because of preterm labor. So you have preterm labor. You can have oligohydramnios because they're losing amniotic fluid. You can have a cord prolapse. And because they are losing amniotic fluid, they can have compression deformities like limb contractures. And they're also at risk of fetal distress because of placental abruption, cord prolapse, and choriamnitis. They are also at risk of necrotizing enterocolitis. This is because of prematurity. Oligohydramnios is also associated with pulmonary hypoplasia, and pulmonary hypoplasia is also associated with prematurity. And because they are prone to infections, because they are premature and it can also be secondary to choriamnitis, they are vulnerable to sepsis, meningitis, bronchopneumonia, and because they are premature, their blood vessels have not yet matured, so they are prone to intraventricular hemorrhage. And for the same reason, the blood vessels are not mature, they can end up with cerebral palsies. So these are some of the complications of Prom and P-Prom. Because of prematurity, they are associated with cerebral palsy, intraventricular hemorrhage, pulmonary hypoplasia, respiratory distress syndrome, and necrotizing enterocolitis. And because of prolonged rupture of membranes, they are also at risk of acquiring choriamnitis. And for the fetus, they are at risk of sepsis, meningitis, and bronchopneumonia. Management of Prom. In this section, I'm going to look at specifically management of Prom. In the next video, I'll look at management of P-Prom. So you have to do a sterile speculum examination. Vaginal examinations, we said, are contraindicated. The investigations we already mentioned, but in addition to that, you have to do antenatal care investigations as well, like test for syphilis, rapid plasma reagent, hepatitis B, and blood grouping. bed rest for these patients to reduce on the mobility of the patient so that they don't drain a lot, and also to prevent cord prolapse. Pad count, you have to monitor how much amniotic fluid this patient is losing. Kick chart for fetal well-being. Maternal pulse, temperature, and fetal heart rate should be monitored every 4 hours. These are the early signs. This will tell you the early signs of choriamnitis. Signs and symptoms of choriamnitis include increased maternal pulse, increased temperature, and increased fetal heart rate. So vitals are important in Prom to monitor choriamnitis, and you have to put the patient on oral antibiotics. Antibiotics use should be amoxicillin or erythromycin with flagyl. Encourage patients to oral hydrate because they are losing fluid, okay? Then you admit the patient to antenatal ward. So most of the patients, about 60 to 90% of the patient will enter spontaneous labor within 24 hours of onset of Prom at term. Okay, so but if they have not gone into labor from within 24 hours from the time they started draining, then you have to induce this patient to go into labor. So that is induction of labor. Caesarean section is reserved only for obstetric indications like, let's say, fetal distress or unstable life. For a Prom less than 24 hours but choriamnitis sets in, then you have to deliver this patient immediately. So this is the end of our discussion on Prom and P-Prom. In the next video, I'll look at specifically the management of P-Prom. Don't forget to subscribe to this channel for more videos. Thank you guys.